Good afternoon, and good evening. Today is March 12th. It's a beautiful day in Boston. Thank you. We have a full house. And thank you for joining us here at the Dana-Farber Cancer Institute. And thank you for joining us today online on this beautiful day in Boston and around the country. The first thing I wanted to do is take a few moments to thank our sponsors. And without our sponsors, we would not be here to offer guidance and support for prostate cancer survivors along their prostate cancer journey. Managing survivorship is extremely important. So let's thank one, the Dana-Farber Cancer Institute, and thank you for hosting us each month. Next, we have our pharmaceutical sponsors, Bayer, Foundation Medicine, Exus, Elexus, Macrogenics, Merck, Novartis, Pfizer. All of these sponsors have played a very important role in bringing you this event. And I wanted to make sure everyone thanks them. Now, first, we're going to move into two parts here. I'm going to give you some background information, and then we have a special speaker from the Dana-Farber Cancer Institute, Dr. Sherzan. And he's a medical oncologist here, and he's going to go into a little bit more detail than what I'm going to do. But first, let me share my slide. So we know from the advertisements and the constant contact reach out to everyone that we're focusing on the role of PSA testing from early detection to monitoring survivorship. Our agenda for today, again, welcome and thank you for coming. I'm going to talk about PSA, prostate-specific antigen background. We have our guest speaker, Michael T. Sherzan. He's a medical oncologist from Dana-Farber. Then we're going to have some Q&A, and then we're just going to close out and have a survey afterwards. So when we talk about prostate cancer, you will hear us say it over and over again. And you're going to hear us say it. I'm going to tell you what I told you, and I'm going to tell you again. And that is new prostate cancer cases in men predicted to increase upwards between 20% between 2019 and 2025 this year. And this data isn't coming from Dr. Google, it's coming from the American Cancer Society. And this is probably the largest increase of any major cancer. So again, this is an alarming finding. It's prostate cancer incidence. And again, they've identified this data. Looking back at old data from 2014 to 2019, that's a 15% increase there. So what's happening? And we're going to learn a little bit more about something that's key in identifying cancer early. So I'm going to tell you what I'm going to tell you, and I'm going to tell you, and we're going to hear it again. 1 in 8 men will be diagnosed with prostate cancer. That's the general population. But high risk African-American men, men with family history, and veterans, 1 in 6 will be diagnosed with prostate cancer. But early diagnosis is extremely important because the data that's coming out of the CDC clearly states that if you're looking at localized disease that's detected locally within around the prostate or in the prostate, the survival rate is upwards above 98% in 10 years. But if it's diagnosed late, it can range between 35 and 18%. But even diagnosed late or at advanced stage, don't give up because there's treatment options that are out there that are coming down the pipeline or in clinical trials. We just want you to have the information and maintain faith. So, know your numbers. Ask questions. Stay proactive. So what do we know? PSA is an essential tool throughout your prostate cancer journey. For early detection, and long-term monitoring. So there's two things here. It's to detect it early, and after you've been diagnosed, then you're able to monitor the disease to see if it comes back. Now, understanding the PSA levels and staying informed about your treatment and follow-up care will help you make the best decisions for your health. Now, your health is a personalized, because we're moving away from any person, anybody else, but to what's best for you, what affects your quality of life. Now, again, when we talk about topics and we talk about differences in race, it's not to talk about a negative. It's important to bring out a distinction between the two. This paper, peer reviewed, published back in November of 2023, was looking at the association between the pre-diagnostic PSA, so using the PSA to make a diagnosis, and looking at the probability compared to Black men to white men. Now, what's nice about this study is this: Black men, we know, are at high risk. But if you look at the veteran population, we start to remove some of the variables that may influence whether or not Black men are getting the same quality of care as white men. So we use veterans. And this study was so important is because there were 75,000 Black men, veterans, that were in this study compared to 270,000 white men. So I'm speaking generally, but these are large numbers. And that's what's important. But the take-home message here was that Black veterans were 50% more likely to have prostate cancer after their first biopsy compared to white. And then if you're looking at the risk level, that Black men with a PSA of 4 have a similar risk as white men with a PSA of 13.4. What does that mean? You can't be waiting until we're 12 or 13 in PSA. We need to be a little bit more vigilant on looking for monitoring our care earlier on. That's just a general take on this. Some other things to take into consideration when we talk about this glycoprotein, this protein, this PSA, it's a testing aid. It tests for initial cancer screening, post-treatment surveillance. So how you're doing after you receive your treatment, radiation or surgery. But you're looking for the term biochemical recurrence. You're looking for recurrence of the disease. Now you can monitor the PSA while you're receiving treatment, and you can predict and determine, get a prognosis on whether or not you will develop metastatic disease that's gone outside the prostate. What you'll hear and you can ask questions about, we'll be talking about PSA velocity. What is that? This rate of PSA increase over time. So we're going to have Dr. Serzon, who's able to answer these questions clearly. PSA doubling, why is that important? Have you heard anything about PSA doubling? Again, you're going to learn about that here. So when we talk about Dr. PSA, that's our icon or spokesperson. And Dr. PSA there's 4 P's of PSA. And what can you do with PSA? You can predict. Now, predicting, screening high-risk men early to gauge their chance of developing prostate cancer. So there's predict. You can pinpoint, diagnosing and estimating tumor aggressiveness. You can patrol. That means you're monitoring survivors to keep an eye on the recurrence of disease. And lastly, you can track the response in advanced diseases. So again, this is recorded. So a lot of these terms that you'll hear today will also be part of a glossary that's in the recording. So you may hear biomarker, high-risk populations, MRI, which is magnetic resonance imaging, PSA nadar, PSA doubling time, PSMA. And I want to make sure that everyone understands there's a clear difference between PSA, prostate-specific antigen, and PSMA, which is prostate-specific membrane antigen. and thinking about the last term is recurrence of disease. So I would like to stop sharing. And I'd like to take a few minutes to talk about our guest speaker. So he's faculty here at Dana-Farber Cancer Institute, Harvard Medical School. He's in the Department of Medical Oncology at the Lank Center, of the GYU Oncology Center here. Now, he has expertise in kidney, bladder, prostate, and testicular cancers, and testicular disease, I should say. And what's important about this doc is that he's doing research about screening and early detection, and monitoring of people who have hereditary prostate cancer. So that's important. So, Dr. Serzan, thank you for coming.
Well, thank you for that lovely introduction. And I'll say, your applause is premature. Make me earn. So let me pull up my slides here. Excellent. All right. Technical difficulties aside. So again, thank you all for joining here in person. Thank you to everybody online. I think over 100 people joining. And when I first walked in the room, it's very apparent that everybody in this room, there's a very strong community here in Boston. I was excited when I was asked to come speak today because I have an opportunity to do two things. Number one, I have an opportunity to learn from you all what your experience has been with prostate cancer, what some of the work that the Prostate Cancer Health Education Network is doing, and then to tell other people about it. And I think that's the power of this group in this room, is that we can then tell other people. We can tell our sons, our daughters, our uncles, our aunts, or other folks about what we learned here today, and then we can have a greater impact. And so that's why I'm excited to be here. I'm going to be talking a lot about prostate cancer and PSA. This is something that I see and talk about all day long. So I'm a medical oncologist here at Dana-Farber, which means I typically see men with prostate cancer, both at early stages when it's localized to the prostate, but also when it's spread to distant parts of the body. And I typically use medications like hormone therapies, chemotherapies, targeted therapies, and then newer medicines that we're developing on clinical trials. And so this is a topic that's near and dear to my heart, and something that I constantly learn something new about. So our topic of today is really focused in on PSA. And as Dr. Crawford was talking about before, PSA has been around for a long time. It stands for prostate-specific antigen. It was first discovered back in 1960, and it was actually detected in sperm, in the semen. That technology was then changed in 1970 when PSA was first in blood. And in 1986, PSA as a blood test was approved by the FDA as screening for the detection of prostate cancer. So that's almost 40 years of experience that we've been using PSA, and we've learned a thing or two along the way. So yeah, PSA has been around for a long time, and we've learned a lot about how to use it. I'll also drive home the point that PSA is a blood test. It is not specific for prostate cancer. Many different things can cause your PSA to go up that are not related to prostate cancer. So as you see here, an enlarged prostate can cause your PSA to go up. Having an infection of the prostate or prostatitis, that can cause your PSA to go up. Obviously, prostate cancer is the thing we're most interested in and focused on, but also if a patient has had intercourse recently, if they had a digital rectal exam done recently, even believe it or not, if they went for a long bike ride the day or two before they had their tests done, that can cause your PSA to go up artificially. And so when we're talking about PSA blood tests and screening, I often encourage my patients to get your test. But if there's any question as to what other factors may be going on, some of my patients say, I'm going to get my PSA checked again a couple weeks later, just to make sure that that PSA number is accurate and that there's not any of these other factors that are causing that PSA blood test to be elevated. As Dr. Crawford mentioned, prostate cancer screening has a couple goals. When we test men who do not yet have prostate cancer, our goal is to detect prostate cancer at its earliest stage. Do we need something again? Same issue. Okay. All right. So again, when we're testing PSAs in men who do not have a diagnosis of prostate cancer, our goal is to catch the prostate cancer at its earliest stage when we have the most treatment options available. That's our goal, but there's obviously risks as well. So not everybody who has an elevated PSA is going to have prostate cancer or is going to have an aggressive prostate cancer. So there is a risk that when we screen a broad population of patients, we may catch a slow growing prostate cancer that was never going to grow, that was never going to spread. And so there is a risk of over diagnosing and over treating a slow growing prostate cancer.
Yeah, so we can't.
Okay, that's fine. That's fine. There's also risks associated with getting a biopsy of the prostate done. And so I don't want to stand here and say that it's not without risk, but I'll also make the argument that the risks, that the benefits do outweigh the risks as far as screening for prostate cancer. As we've done prostate cancer screening over the last 40 years, we've gathered a lot of information. Hundreds of thousands of men have had their PSA blood tests done, and we have done these studies and now come out with guidelines as to who should be tested, how often should they be tested, and then what do we use that information for. And this is this slide goes, I'm gonna make this a little bit bigger that way. Let's see. This slide goes through screening guidelines for the general population. So for a man with an average risk of prostate cancer aged 45 to 75, they should talk with their doctor about the benefits and the risks of having a PSA blood test done. However, for those men who have a strong family history, their father had prostate cancer, their uncle had prostate cancer, their brother has prostate cancer, or if they have a genetic mutation, say the BRCA1 gene, the BRCA2 gene, or if they're of Black or African-American race, those are patients we know are at higher risk of developing prostate cancer. And for those patients, I actually do recommend we start getting PSA blood tests at the age of 45. These are a couple different cutoffs that we think of, or numbers, just to give you a ballpark. If that initial PSA blood test is greater than 3, then we would move on to get a MRI or image of the prostate and a biopsy to see if there are prostate cancer cells there. If the PSA is somewhere between 1 and 3, then I would say let's continue to watch that PSA with another blood test every year or 2. And if the PSA is less than 1, then the risk of prostate cancer is quite low. So we could maybe get away with doing a PSA blood test every 2 to 4 years. Again, these are very rough guidelines, but I think it's helpful to have a sense of what are some of the numbers that we're thinking about. That way you can have something in your mind and have a framework for how we make these decisions. This is one of the guidelines that I pull up just to show you that the guidelines are different. In one set of experts come up with the guidelines, and then another set of experts may come up with a different set of guidelines. But this kind of just is a graphical description of what we went through on the previous slide. Again, these are the NCCN guidelines, the National Comprehensive Care Network. These guidelines have been put together annually, and they're changed based on new information that we learn. The next slide that we'll go through, this is the AUA, so the American Urological Society. So these are surgeons who have come up with these guidelines. And you see their age cutoffs are a little bit different. Their PSA cutoffs are a little bit different. So just to appreciate that, the guidelines change as we learn more about prostate cancer. I cannot tell you how many of my patients have sat in my office and said, my primary care physician told me I no longer have to get my PSA checked, and now I've been diagnosed with prostate cancer that spreads to distant parts of the body. That's because as a group, as a medical profession, it was discouraged to have your PSA checked nearly about 10 years ago. Now that pendulum is swinging back, and we're starting to recommend more routine PSA screening. But just to appreciate that these things change over time, and what your doctor recommends today will likely be very different than what they recommend a couple of years from now. So what I recommend for all of my patients, all of my family members of my patients is to have a relationship with your primary care doctor, with a urologist, where you're discussing a specific prostate cancer screening plan for you. How often should you get screened? You know, what are the numbers that we're going to use to then do further investigation? I always say that a second opinion is encouraged. It may not be a perfect analogy, but I think about cars. And if there's something wrong with your car, you're not always going to go to the first mechanic and take their opinion and get it fixed. You're probably going to talk to more than one person, get more than one opinion, run it by a trusted friend or colleague who may have had a similar issue, and then use that information to make an informed decision. I think about prostate health in a very similar way. You want to make sure you're talking to more than one doctor, more than one team, getting similar information. That way you feel empowered and comfortable about the plan. And as I said, prostate cancer screening guidelines do change over time. So staying informed, asking questions, coming to events like this where you're learning what the latest guidelines are, and then using that information to get the best care. Now, that's PSA testing in men who do not have a diagnosis of cancer. PSA is actually also a very good test for men who have been diagnosed with prostate cancer. And it tells us in very rough terms how aggressive that prostate cancer is. Now, this is a complicated chart, but these are men with localized prostate cancer. And we think about a couple different PSA cutoffs. So if you've been diagnosed with localized prostate cancer and your PSA is less than 10, we typically think of your prostate cancer as a low risk of being able to spread to distant parts of the body. Whereas if your PSA is higher, it's 10 to 20, then we would say that you have an intermediate risk of your prostate cancer spreading to distant parts of the body. And if your PSA is greater than 20, that would be high risk. And again, this is for men with localized prostate cancer. So PSA not only can detect whether or not there's cancer there, but it can also give us an idea of how aggressive that cancer is. And from my perspective, how aggressive we need to be with hormone therapy, radiation therapy, surgery, all given in an effort to cure patients of localized prostate cancer. For men who have localized prostate cancer that has not spread to distant parts of the body, and we're talking about doing active treatment, there's two primary options that we talk about. One is surgery to remove the entire prostate, and the other option is radiation with or without hormone therapy. They're both effective ways to treat prostate cancer and have benefits, but also risks associated with them. So in my clinic, a patient will typically meet with me. We'll talk about that chart we went over previously, and then they'll meet with a surgeon, they'll meet with a radiation doctor, just because we think it's so important that you hear from all different members of the team what the benefits of those treatment options are and what the risks are, so that we can come up with a plan together. Now, after a man has either surgery or radiation, I often meet with them after they have these procedures done, and there's a lot of questions that come up. How successful was my surgery? How successful was the radiation treatment? What's the risk of the cancer coming back at some point in the future? When should I consider more treatment to prevent the cancer from coming back? And these are some of the questions that we'll go through in our question and answer, but things that I see literally every week, and we're used to talking about. The PSA blood test is really one of the best tools that we have. It's low cost, it's easily accessible, and it's something that we can use to monitor prostate cancer very, very closely. So in summary, again, PSA is key across all stages of prostate cancer. For men who do not yet have a diagnosis of prostate cancer, it's good for screening. For those who have been diagnosed with prostate cancer, it can give us an estimate of how aggressive that disease is. And for those who have received treatment for prostate cancer, it can give us a sense of not only how successful that treatment has been, but also whether or not we need to think about doing further treatment in the future. Lastly, I'll also say that this is an opportunity to take back control. When you're given a diagnosis of cancer, there's a lot of uncertainty about what treatment you're going to have, about how successful it's going to be, whether or not the cancer comes back. This is a thing we can do to take back control, to know our numbers, and to be proactive about our health. So with that, again, I'll thank you all for your attention, and we'll move on to our Q&A.
So, Dr. Shazan, kind of stay up here with me for a second. I want you to just take a few minutes again. Control. And know your numbers. But right now, I wanted to stay up here because this is your time, whether you're here in person or online, to ask someone, an expert in the field, about the questions that you're concerned with. I think Jerry's been keeping track of those, so he's going to be able to ask you these questions. Right, Jerry? Okay. Well, while you're waiting for Jerry, there's one question that came up. They're saying is, do you need a digital rectal exam when you're screening, or can we just get the blood test first?
Yeah, it's a good question. I will say, so before we had PSAs, the digital rectal exam, where the urologist would examine the prostate, was the best tool that we had. And if they can feel a mass on the prostate, then they would get a PSA blood test and potentially further imaging. There have been many, many studies done on digital rectal exams, and they're not a very good test of detecting prostate cancer. As you can imagine, if you have a primary care physician who does not do many of these exams, their exam may not be calibrated. And so we think that PSA is a much more reliable screening test. Digital rectal exam is still in our guidelines. My hope is that over the next several years that we replace digital rectal exam with a much better test called an MRI of the prostate, which will be able to look at the prostate and hopefully be an even better screening test than the digital rectal exam. But a wonderful question.
So we have someone from the audience.
I just wanted to mention, maybe I missed it, but you said that we should start getting our prostate exams at 45. So if your family members and your father, uncles had prostate problems, wouldn't you consider going earlier?
Yeah, it's
Sooner the better?
It's a great question, and I think to clarify one point, I think getting a PSA blood test as early as the age of 45, I would recommend that. Whether or not we should be screening patients earlier, there's a potential benefit. We may discover the cancer at an even earlier stage, but the likelihood of developing prostate cancer at that early in age is relatively low. And so then we're talking about some of the risks of screening patients in their 20s or 30s may actually outweigh the benefit, and that we're less likely to detect prostate cancer in a 20-year-old man than in a 50-year-old man. But I'm with you. For patients who have a strong family history or known genetic mutation, we start as early as the age of 40. Or you could make the argument 10 years earlier than the earliest diagnosis of cancer. So if your brother was diagnosed with prostate cancer at the age of 45, maybe you should start at the age of 35.
Right. Okay, Jerry has someone online, and then we have someone here also.
Okay, first online question. Why would we leave a cancerous prostate in the body? How many active surveillance patients have reduced the cancer?
Yeah, wonderful question. So
Excuse me, I didn't really hear the question. Can we?
we'll repeat it, yeah. So some men who are diagnosed with localized prostate cancer have what we call low-risk prostate cancer, meaning based on how it looks under the microscope, the PSA numbers, the likelihood that that cancer would grow and spread is exceedingly low. And for those patients, we actually recommend they don't have surgery, they don't have radiation. Rather, they are on an active surveillance where they're getting repeat MRIs, repeat PSA blood tests, repeat biopsies. The benefit there is that we're not rushing into treatment. We're not exposing those patients who have a very slow growing cancer to the risks of surgery, which could be things like incontinence or erectile dysfunction, or radiation, which can cause damage to the colon that surrounds the prostate. So it's trying to use the information that we have to only intervene when it becomes necessary. And I have many patients who have low risk or low grade prostate cancer, and they've been on surveillance for many years where they're not dealing with the side effects of surgery, they're not dealing with the side effects of radiation, and they may have access to even better treatments in the future if and when they need treatment. But a great question. Yeah.
So just to add on to that question, you did monitor them, what, every 6 months?
Correct. Yeah. And I always say active surveillance is only as good as we who do it. So making sure that there's a plan to get PSA checked every 6 months, to get an MRI done once a year, to have repeat biopsies if that PSA goes up, if that MRI looks more concerning and the cancer's telling us it's more aggressive and needs to be treated.
So we have someone in-house.
Okay, can anybody hear me?
Yeah.
So it's a two-part question. The MRI, if nothing shows up in the MRI and the person is high risk, meaning that there were cancer in the family, prostate, sisters had breast cancer.
Yep.
Nothing shows up in the MRI. There was no lesions, but then the MRI is taken 2 years later and lesions show up.
Mhm.
So is that an aggressive slow moving prostate, or is that more of a faster, slow moving,
Yeah. The first part of your question is, what do we do if your PSA is elevated, but your MRI does not show us anything? There have been a number of recent studies that say we can rely on that MRI if nothing has shown up, to not just do a random biopsy of the prostate, but to watch very closely. The other thing that you could decide is say, even though the MRI has not shown anything, I'd like to have a biopsy done out of an abundance of caution to get that information. And you wouldn't be wrong to make that decision. But again, I think the recent data is telling us the MRI is a reliable test. The second part of your question is, if the MRI does change, if it looks more aggressive, it doesn't necessarily mean that it's a fast growing prostate cancer. It just means that during that 2-year period, something changed. And then we really do need to get a biopsy, look at those cells under the microscope to tell us how aggressive it is.
And one last question. So the chart that you showed, the PSA, if it's less than 10, and it's a low
risk.
Is that for both black male and white male?
So Dr. Crawford brought up some really interesting points in that that is in all comers. So regardless of your racial or ethnic background, but it's intriguing to see that while a PSA in that study for men who had a lower PSA actually had more aggressive prostate cancer. So that does not account for that, but that's an individual risk factor that I think is really important to have that discussion with your doctor and say, hey, listen, my PSA might not be the most reliable in my particular circumstance, and therefore we should talk about more intensive monitoring or treatment based on my individual factors.
Okay, I wanted to dovetail on that with another question. And that question is, how does a PSA doubling time fit?
So PSA doubling time is in that period of time after we have surgery or radiation, where the PSA is usually at a very low level. So after surgery, when I see my patients, their PSA should be 0 because they no longer have a normal prostate place. If that PSA number is not 0, then my antenna is up to say, is there some evidence of prostate cancer in a part of the body? And the numbers I talk about there are pretty low, like 0.1, 0.2. And when the PSA is at such a low level, oftentimes if I do a CT scan or a PSMA PET scan, I don't see any evidence of prostate cancer, but there's something that's creating that PSA blood test. And the PSA doubling time helps us to understand how aggressive or how rapidly dividing those cancer cells are. So to put some numbers behind it, if we checked a PSA today and it was 0.1, and 6 months from now, it doubled to 0.2, we would just call that a doubling time of 6 months. If we then forecast into the future at 12 months, it'll be 0.2 times 2, 0.4. And then when we go to 18 months, it'll be 0.2 times 0.4 times 2 to 0.8. That's a pretty fast doubling time. That tells me that that's an aggressive behaving prostate cancer that has a higher likelihood of showing up at some point in the future. That's one scenario. We think about a slow doubling time. If today PSA was 0.1, and if in 6 months the PSA was 0.11, that's a pretty slow doubling time. That doubling time is well over a year, and that tells me that the prostate cancer is likely slow growing, and we can be reassured that we can continue to watch things very closely and not necessarily jump into further imaging or further treatment at that point.
I have another online question. If a prostate is removed, can a man have a normal sexual performance?
Yes, they can. Oftentimes I encourage my patients to have a discussion with their surgeon about the risk of erectile dysfunction after surgery. When surgery is done, there are a lot of nerves that surround the prostate. And if those nerves are affected by the surgery, they can cause erectile dysfunction. Some men are eligible for a surgery that's nerve sparing, that allows the nerves to stay intact and just removes the prostate, in which case the risk of erectile dysfunction is much lower. So that the type of surgery that's done can sometimes decrease the risk. There's also things like pelvic floor physical therapy, medications that we can use to regain that sexual health after either surgery or radiation. And again, I think that's why having a very good relationship with your surgeon, with your care team to help navigate those, because sexual health is important. You know, I'm here, I treat prostate cancer, but I'm also really focused on what's the quality of life that we're giving our patients. A patient who's diagnosed with prostate cancer in their 60s, who's cured, but may deal with incontinence or erectile dysfunction for the rest of their life, that's a big deal to us. And we want to do both things at the same time, treat prostate cancer, but also weigh what are the implications for quality of life. Yes.
My next question is, I had the seed implants. Are they still doing seed implants?
We are, yeah.
Okay.
The technology has evolved over the years, and so I'm not exactly sure when you had yours put in, but
15 years ago.
15 years ago. So,
Right here.
so clearly,
So I just want to be
it's-
clear, that's a 15-year prostate cancer survivor?
Yes.
Yeah.
Okay.
Yeah. You know, we still use seeds. Not a radiation doctor, but my simplistic understanding is much of the radiation we do is from the outside in, whereas the radiation seeds are kind of radiation from the inside out. And so we still use seed implants for some patients. Again, that's why I think it's so important to meet with a medical oncologist, a surgeon, and a radiation doctor to talk about all those different options.
Question I have, aside from hereditary causes of prostate cancer, what is the cause for the majority of men that's not hereditary?
So the question was essentially what causes prostate cancer if it's not a genetic risk factor? I think largely we don't know. There's a lot out there about general health, a lot out there about certain types of diets that may decrease the risk of prostate cancer. But for the vast majority of my patients, if it's not a genetic risk factor, I don't know for sure why they developed prostate cancer. We know that all of our cells in our body are constantly growing and dividing and changing and becoming damaged cells and repairing themselves and then becoming damaged and repairing. It's for some reason that process of damage and repair becomes interrupted and the damaged cells are having an opportunity to grow and to change without being taken care of by the body. But largely, I think we don't know, and we're trying to find out more about why men are developing prostate cancer and what we can use to prevent that from happening. Because as much as what I do is exciting and very rewarding, I also realize that if we could prevent the prostate cancer from developing in the first place, we might have an even bigger impact.
So none of the research basically addresses that.
Not yet, but we're working on it.
And they're working on it at the Dana-Farber.
So we have another online questions. I have a rising PSA of 1.3, 3.5 years post-surgery. The PSMA screen is showing nothing. Does PSMA pick up all forms of prostate cancer, or can the PSA test be picking up something else?
Great question. And this gives us an opportunity to talk about if your PSA is going up. And as we discussed before, after surgery, that PSA number should be 0. So if that PSA number was 1.3, if I heard correctly, that tells me that there's some prostate cancer in the body. The next thing we do is try to figure out where is the prostate cancer, and just as importantly, where has the prostate cancer not gone? And that's where we do scans to try to figure that out. The scan that we currently use in 2025 is something called the PSMA PET scan. As Dr. Crawford mentioned, that stands for prostate-specific membrane antigen, and it just has to do with the dye that they use to scan the body. It does look at all areas of the body, and it's very good at detecting small amounts of prostate cancer in the body. However, as our questioner brought up, it's not a perfect test. It may not detect a tumor, and in that scenario, I think there's likely to be prostate cancer. We just can't see it yet. And this is where things like PSA doubling time become very important, because if we don't see anything on scans, PSA is really the only thing we have to tell us how aggressive the cancer is behaving and whether or not it would come up again in the future. There, I think it's very important to talk with not only the medical oncologist, somebody like myself, but also a radiation doctor about what options we have for trying to detect prostate cancer and eradicate it before it has the opportunity to show up somewhere else.
Okay, I have another online question. How is the PSA test used to monitor post-treatment, and what is the guideline for testing frequency?
So I think we've talked a lot about how we use PSA after surgery. And usually after surgery, as we said, PSA should be at a very low or undetectable level. I usually am getting PSAs on my patients every 3 to 6 months after surgery. I typically do that for the first 2 years after surgery. And if that PSA number is stone cold normal, undetectable, then I would increase the frequency to maybe every 6 months or every 12 months. And then at the 5-year mark, maybe check once a year. On the flip side, for radiation, after radiation, that PSA number may not go to 0 completely, because as we said before, PSA is not only made by prostate cancer, but it's also made by normal prostate tissue. And when you have radiation, you still have a normal prostate in place. And so what we look for is that PSA number after treatment often goes down. But if that number starts going up and goes to 2 above the lowest number, then our antenna is up to say, is there residual prostate cancer left in the body? And that's when I do a PSMA PET scan, as we talked about before, to try to detect that cancer. So it very much matters not only what your number is, but what treatment you had and what thresholds we're looking for, whether or not the cancer has come back. Yeah, go ahead.
During the surgery, you mentioned earlier about keeping the nerves intact. So if someone's doing a robotic surgery, are they trying to keep the nerves intact while they remove the prostate? So how is that different from you saying there was a different procedure? Is that
Very often they are. And in this day and age, most of my patients are having an MRI done before their surgery, which helps the surgeon determine whether it's safe to leave the nerves intact, or if that's high risk. So I have some patients where the tumor is kind of pushing against the capsule of the prostate. And for that patient, it's probably makes sense to just remove everything. Whereas if there's no evidence of the prostate cancer pushing outside of the capsule and they think they can safely leave or spare the nerves in that situation, they'll often do that. Surgeons, they always want to get the best outcome for their patient, but they also rely a lot more on the imaging than maybe I would.
I have another online question. University of Michigan has a study that can diagnose PC by a urine test. Not sure, is this have been approved as a treatment tool? Are you familiar with this urine test?
Yeah, great question. So as I said before, PSA has been around for 40 years and it's a good test, but we've spent a lot of time also talking about how it's not a perfect test and how we need new tests. The prostate, as we think about it anatomically, sits right around the urethra. And so a very logical place to look for the presence of prostate cancer is in the urine, which is passing through the prostate area anyway. There's a number of different tests that are being evaluated, not only in the blood, but also in the urine to try to detect prostate cancer at its earliest stages. As you see here, it has not yet made its way into our national guidelines, but there's certainly a lot of exciting research being done for urine tests, but also other types of tests that can augment or enhance our ability to detect prostate cancer. So very promising research, but not yet ready for prime time.
I have another question. Up to what number is PSA considered non-detectable after robotic prostatectomy? And at
So
what number do you
The
need?
number I typically think of is 0.2. That being said, if my patient after surgery has a PSA of 0.1, I'm going to watch things very closely. I'm going to get another PSA usually maybe 3 months later, rather than waiting for that full 6 months. But the guidelines tell us we should wait until that PSA is at a 0.2 level, because I have some patients where rather than prostate cancer, there may be a small retained piece of normal prostate tissue that causes a very low level PSA after surgery. However, if that number goes above 0.2, it's much more likely that it represents prostate cancer.
Okay, fantastic. That was the second half.
Okay, I have statements more than questions.
Right?
And the first one being is that you today explained that there's very different treatment that we receive. I had nothing like what you were talking about. MRIs, where they talk about whether they can save the nerves or not, or anything like that. No follow-up and this type of stuff. So that is very different treatment. I don't know where you are, but I sure would like to have seen you when I went through this process, because my treatment is nothing like you're talking about today. So that's one. Two, how can I say this? I'll say it this way. The current political environment where science is being questioned, that we long thought was correct, where it's under attack.
Mhm.
today. Research funds and everything else. So, just saying.
Yeah, yeah.
So one thing was important, I want to comment on that is that there's a body of research that exists today that says one thing: early detection screening and get your PSA test. If we can get over that hurdle of getting screened early, that's a significant hurdle. Men who are at high risk need to be screened or begin discussions with screening at age 40. So a question that came up that was very interesting, and that is, if you have been treated for prostate cancer, radiation, or surgery, how long should you monitor for recurrence of disease?
Yeah, great question. I think a lot depends on what we find and what we know about the prostate cancer. Obviously, somebody who is relatively young, who had a high PSA to begin with, who had some aggressive features under the microscope, that's somebody I'm going to watch very closely. I think the most critical period in my mind is that first 2 years for the cancer to come back, and every year beyond that becomes a milestone. I always recommend that my patients continue to be followed lifelong. And that doesn't mean you have to come in and get PSAs and MRIs done every 6 months. I think it's very low-lying fruit to get your PSA checked once a year by your primary care physician, because even for patients who have had excellent surgery, fantastic radiation, there's sometimes small microscopic cancer cells that break off and that hide out and that take 10, 15, 20 years to develop into a tumor. And so I think the most critical period is that first 5 years after getting treatment. But I always recommend my patients at least get a PSA blood test yearly for the rest of their life, just to make sure that we're surveilling and that we have a very close eye on whether or not the cancer has come back.
Versus if you're screening and you haven't had the disease, you're suggested that you can screen up into age.
Yeah, it's another great question. I have some 75-year-olds who are more active than I am. They ride bikes, they run marathons, they're in fantastic shape. Their life expectancy, maybe 100. Hopefully it's beyond that. And you could make the argument that if we caught a prostate cancer for that patient at the age of 75 or 76, and prevented it from growing and spreading and limiting their life expectancy, we've done a huge service to that patient. So a lot kind of depends on other medical factors that come into play, what treatments we may be proposing, but it's having that discussion with your doctor. If you're a really fit 75-year-old and you say, hey, there's a strong family history of prostate cancer, I want to keep a close eye on this, I think I would be on board with that. On the flip side, if you said, hey, I'm 75, I've had 3 heart attacks and I go to dialysis 4 times a week, I'd say there's probably more pressing issues that we need to address, and getting your PSA checked might not be the top of the list.
So thank you very much. So what we want to do is, first thing, can you grab a mic, please?
Thank you, doctor, for coming here today. Okay, thank you, doctor, for coming here today. I have 2 questions. The first question, you gave example about how aggressive the PSA level is. Like you gave example about like 0.1, then 6 months 0.2, and stuff like that. So in that case, like in 2 years, like you see how it's like going like fast, can you give medication instead of like just wait for it to happen? Can you give the patient medication for it to slow down?
Absolutely. So after surgery, a very straightforward option, if the PSA is going up, if there's recurrence of prostate cancer where the prostate used to be, we very often do radiation to the prostate bed to try to eradicate any residual cancer. If a patient had radiation first, it's very hard to do surgery after radiation. And so there, we're much more talking about either repeating radiation, which I do have some patients who can get radiation a second time, or using medicines that I use, like hormone therapies that work by decreasing testosterone to starve the prostate cancer cells of their food and prevent them from growing and spread. Now, any medicines that we have do have side effects to them. And so we have to think about what's the risk of the cancer coming back. And that's where we rely on that PSA doubling time to understand that risk versus what's the risk of side effects. Hormone therapy can cause fatigue, hot flashes, night sweats, almost like the male version of menopause. And so you have to think about what are those competing risks and how can we use that information. For some of my patients, we do start hormone therapy very early because we're seeing something that's telling us the cancer is growing and we want to prevent it from going to a distant part of the body. But there's absolutely things we can do. And I'll also make the argument that active surveillance is doing something. You know, a lot of people think, you know, if I'm not getting treatment, are we doing anything? Surveillance is a really important tool in our toolbox. It helps us understand how aggressive cancer is and intervene if and when it's really necessary.
Okay.
So thank you very much. Dr. Suzanne, stay there for a second. Jerry, I want you to launch the survey questions. And if there are any additional questions that you in the audience would like to ask, we can address. And if we're not able to get to your question, because there's a lot of questions, please give us some time and we'll be able to respond to those questions by email.
My second question was vasectomy. Research has shown that vasectomy slightly increased the risk of having prostate cancer. In your opinion, is that true? Have Dana-Farber done research on that?
I don't know if we've definitively answered that question. I think, like you alluded to, there's some evidence that there may be increased risk, but I don't think it's quite conclusive for us to know that for sure. But it is something that we're continuing to study and try to gather information on because it has implications for many ways. A gentleman in the back also made two statements that I want to comment on. The first was how your treatment may not have been quite as comprehensive as what I described. And that's where I think second opinions come into play. You know, no doctor is ever going to be offended if you say, hey, I'm going to go meet with somebody else and come back and want to get more information. I also feel incredibly lucky here at Dana-Farber. I've got wonderful surgeons, wonderful radiation doctors who I work with on a daily basis and enjoy great relationships with them. So you want to be at a place that sees a lot of prostate cancer, that encourages you to be empowered about your health. The second thing I'll say is you made some comments about the current political environment, and I won't go into all that except to say it's critically important. Research saves lives. There was an appropriation that got cut by 57%, and I think it comes out to somewhere over $100 million specific for prostate cancer. And while I can't control any of that stuff, I was also on the phone with my representatives yesterday saying, we need this money, we need this research. It's investing in people, it's investing in our communities, it's investing in our health. And so to the extent that we can control what we can control, PSA is taking back control, we can make our voices known, we can come together and let the powers that be know that health is important to us, and advocate for ourselves.
One quick question. You mentioned about testosterone. Is there a percentage of testosterone in a man that contributes to him having the prostate cancer? And is it better to have a lower percentage of testosterone in your system prevents you from having prostate cancer?
It's a good question. I don't think we know in those men who have not yet been diagnosed with prostate cancer. I wouldn't recommend manipulating or decreasing testosterone to try to prevent prostate cancer from coming on, because when we decrease testosterone, that also has side effects to it. So there's also the case where some men just don't produce testosterone and they need to be on supplementation just to have a normal testosterone level. For those men, I think the addition of a normal level of testosterone does not increase their risk of prostate cancer, they need that testosterone because that low testosterone may have its own implications too.
What represents a normal level?
Yeah, big range. I think it goes somewhere on our scale, it goes from 192 to 750. And that number can fluctuate based on the time of day that we're measuring it by a number of different factors.
Thank you.
Sure.
Okay, what I would like to do is one, Dr. Suzanne, we have people that are online and we have people who are here. What would you, if you wanted to leave them with a singular message, what would you want to leave the audience with?
Yeah, I thought a lot about this question, which you sent me earlier this week. I think it's really about taking control of your prostate health. And I sit here, you know, as a man in my late 30s with a son, with uncles and a father who we got together at a family reunion this summer, and people are talking about their PSA numbers. And it's kind of a taboo topic. You know, it has to do with sexual health, it has to do with cancer, and nobody likes talking about either of those things. But if we can normalize that discussion and say, I want to learn more, I want to understand what my risk is, I want to be proactive about my healthcare. Believe me, I'm not the greatest with my primary healthcare, but if we can normalize that discussion, if we can share information, that's going to make a huge difference to decreasing the likelihood that our loved ones come down with prostate cancer, and to take back control and to, you know, try to set aside some of the shame and some of the uncomfortable feelings that may come with talking about prostate health. I think that's what we need to make a big impact in this space.
So Dr. Suzanne, thank you very much. And can we give her a big hand and a big hand online or a big hearts and hands online?
Amen.
So what I would like to do is, Jerry, can we take a look at the poll? Okay. So I'll just switch out with you. Thank you again.
Mhm.
And so if we look at the poll, the first question, do you understand how often prostate cancer survivors should get their PSA level checked? 93%. So you know he did an excellent job. And we said 6% said somewhat, and 1% said no. Question 2, do you understand the significance of PSA doubling time? 77% said yes, 15% said somewhat, and 8% said no. So again, that's going to be a topic that we're going to dig into a little bit more the rest of the year so we understand screening, monitoring of PSA. Number 3, were you satisfied with this meeting and the presentation content? 67% were very satisfied. 33% were satisfied. So no one was dissatisfied. So that's great. Next question, how do you rate the speaker? Oh, I guess you knocked it out of the park. 92% said excellent.
Well, I'm only half of that, so you're
No. Okay. You brought it home for us. And 8% were good. 8% said good. Number 5, do you feel more confident managing survivorship challenges after the webinar? 81% said yes. 19% said somewhat. And there was no one that said no. So we'll keep on doing our very best to bring you content and making sure everybody understands how to manage their survivorship. Next question. How did you feel about the pace of the webinar? Too fast? 4%. Just right? 94%. Too slow? 2%. Number 7, would you attend another survivorship focused session? 100%. Yes. Would you recommend this session to others? 100% said yes. Woo. Did this program allow adequate time for audience Q&A? 86% said yes, and 14% said somewhat, but no one said no. And then the last question that we have for you is this. We're going to look at who was in the audience. So prostate cancer patient and slash survivors, 80% were prostate cancer patients or survivors. 4% were caregivers or family of a prostate cancer patient. 4% medical professionals, 2% advocates, and 2% clergy. So I wanted to thank you. I was also wanted to do one. If you're in the Boston area, I want everyone to join us at the end of the month. So we're talking about, we want you to join us at our prostate cancer community rally at 12th Baptist Church, 160 Warren Street, Boston, Massachusetts, March 29th between 9 a.m. and 3 p.m. This is free PSA testing, free lunch, educational sessions, and we're also going to be raffling off Celtics tickets. And so, and again, I want to thank you, sir. I'm sorry, what'd you say?
Just give me those tickets now.
I said, well, you got to show up. Got to show up and put your hat and your ticket in the ring. So again, Dana-Farber Cancer Institute, thank you. Sponsors, thank you. Audience, thank you for being there with us. Again, we had a very large population online. We had a full house here in the Dana-Farber. Thank you very much. And again, thanks for our speaker.
Amen.
Good time out of his day. When it's done, right? Come out and educate our folks.
Amen. It's great.
Thank you.